EKG of the week. Let's look at another real-life EKG. This one was sent to me with a tiny bit of clinical history, literally just 3 words. And that puts the whole thing kind of in context. But without it, I think I had an idea of what was going on regardless. So let's take a look at this EKG. Pause the video, look at the thing, and come back when you think you know what's going on with it. All right, let's take a look here. So when we start looking at the EKG, as always, we're going to go through the algorithm because that way you don't miss things. So rate, rhythm, axis, intervals, and blocks, ischemia, infarct, and then I'll kind of call it general patterns and then an overall impression. So when we look at our rate here, if we count the complexes going across the rhythm strip down at the bottom, then we get, let's see, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16. 16 times 6, because it's a 10-second strip, so there's 6 of them in a minute. 16 times 6 gives you, mental math, 96, right somewhere around 100 there, and this is, again, give or take, but probably close enough for government work. It's going to be somewhere around 100. We'll call this 108. I think I missed one when I just counted it just now. Either way, that's okay. So rate somewhere around 100, maybe mild tachycardia. How about rhythm? It looks like we have, do we have a P wave? Yes, we have P waves. Do we have P waves before each QRS? Yes, we seem to. They all look more or less the same. And is there a QRS that follows each P wave? We don't see any drop beats. I think that is sinus rhythm. So we'll call this sinus tachycardia at a rate of 108. Rate, rhythm, axis. Again, if you had to skip axis, you could, but in this case, let's just check it out real quick. So the electrical activity, the main direction of the electricity in the heart, it is positive in lead 1, which means it goes from the right shoulder to the left shoulder, and it is positive in lead AVF, meaning it goes from the head primarily down towards the feet, going in that direction. So this is going to be a normal axis, and then if we want to confirm upright in 2, gives us along the normal sort of axis of the body itself, so, or of the heart. And so let's say that this is a normal axis. The biggest thing, up in 1, up in AVF, we could confirm with 2 if we wanted. But we'll call this a normal axis. It's somewhere close to that horizontal line, that lead 1 line. Anyway, rate, rhythm, axis, intervals, and blocks. When we look at our intervals here, let's find a good-looking segment that we can do a little bit of measuring on. This guy looks pretty good, and we'll stop right there. So our PR interval should be less than 1 big box, i.e. 5 little squares, and it looks like it is from the beginning of the P wave to the start of the QRS complex. That looks like it is normal. PR interval, our QRS looks, should be smaller than 3 little boxes. In this case, it looks like it's 1, 2-ish. So that would be a normal QRS size. And by the way, you can have a short PR, which I'm just kind of glossing over usually because you don't often see it, but this one's okay. And then let's look at our QT interval here. Again, between the R waves, and you could do it, on this one because there are little R waves there, but you could do it down here as well. The R to R interval, just again as a broad cheat way to kind of do it, the T wave should finish before halfway between the 2 R waves. So if you look at the distance from this, let's just call it this beat, this R wave to this beat, this R wave, does the T wave get finished before you get halfway there? And it looks like it does. It's maybe right on the borderline, but I don't think this is certainly any prolonged, really clinically significantly prolonged QT interval. So we'll call these normal PR, normal QRS, normal QT. Nothing else looks really out of place. Let's call this normal. Intervals, we don't see any sign of blocks otherwise, such as atrial, left bundle branch block or right bundle branch block, one of those. Rate, rhythm, axis, intervals, and blocks, ischemia and infarcts. Running through, we can examine kind of quickly again. I usually, when I'm handed an EKG, I just first scan it to look for ST elevation, which is the big thing that everybody gets excited about, and then go back and look at the rest of it. But when we scan through, I'll start up at lead 1 here. No ST elevation, looks like about the same. There's these little funky things going on here, by the way, that I think are just artifact. But no ST elevation there. When we look at it on our lateral leads, no ST elevation there. Tiny bit of ST elevation in V2 and V3. V1 doesn't seem to have much. V2, V3, but again, it is normal to have some elevation in V2 and V3, and this looks like just at a box, which is well under the criteria that we would use to diagnose STEMI, and it looks wrong anyway, and there's other stuff going on. So we don't see significant ST elevation. Do we see a lot of ST depression or flip T waves to suggest ischemia? Not a lot. A little hard to tell here. You got to find one where the TP segment is kind of horizontal and there's not a lot of baseline wander, which is a little artifacty, and the paper is a little bit bent when it was scanned, it looks like, but nothing too awful much in terms of ST changes. Certainly no big ischemia. Maybe there's a little flip T wave there. It's a little hard to tell, though. Again, kind of artifacty. But I don't see any obvious signs of ischemia, and you would certainly want to compare that to old morphologies if that happened to be the case. But nothing looks like ischemia or an infarct as far as I can tell. And so we got rate, rhythm, axis, intervals, and blocks, ischemia and infarcts, and then, again, what I call general patterns, meaning things you just kind of have to know what they look like. And as we gaze upon these things here, nothing really shaken out as too awful funky. QRSs look, kind of normal-ish. But the one thing that does come out is this QRS in this T wave here. That T wave looks awfully big. And not only big, but it's distinctly big. It's narrow and it's pretty pointy. And we think about T waves being big in kind of two cases that should jump to your mind. One would be a hyperacute T wave, i.e. the early sign of a STEMI before you really develop the ST changes with it. And the other is hyperkalemia. And this doesn't look like a hyperacute T wave to me. This looks pointy and sort of more narrow than I'd like to see with a hyperacute T wave. Usually hyperacute T wave is this big fat thing. These narrow little pointy T waves like that one, and even that one, even though it's not so tall, it's very pointy. That is indicative of hyperkalemia. And again, the note that was sent with this EKG just said potassium 8.1. So that is, of course, a laboratory diagnosis there, but the EKG certainly suggests it. So, one can imagine all sorts of different scenarios why this person's potassium may be up. One of the more common reasons, of course, is, end-stage renal disease and dialysis and that sort of thing. But if you're handed this EKG and you looked at it, your first thought would probably be, I wonder what that potassium is. And if the person became unstable, I would certainly probably act on that EKG and go with some calcium. Now, the one thing that you don't see, or the couple things that you don't see with on this EKG that sometimes you will see with severe hyperkalemia, the peak T wave is the kind of the first thing, but the peak T wave it just says that it's high. When you really get worried about it is when you get QRS widening. And if you remember the changes, it's like pulling on a string, like you pull apart the whole complex, grab on each end, and it flattens the P wave, it makes the QRS wide, and eventually gets to that sine thing. We don't see that here, we just see the peak T waves. So still something to be concerned about, but again, some people will get a peak T wave at a potassium of 6.1, so just a little bit elevated if they're not used to it. Some people who are used to it essentially will, just get these kind of minor changes even when their potassium's super high. So, something to be aware of. I'm going to say again, we have a note about the lab diagnosis of it. I will say that the pattern looks like the pointy T wave that's most consistent with hyperkalemia, although we don't see any of the other terrible signs of hyperkalemia that goes along with it. And if you have any questions, let us know. Otherwise, we'll see you next time.